So thank you guys for being here. I'm Amy Weber. I'm a licensed professional counselor in the United States and a PhD candidate in counselor education and supervision. And today I am talking about reducing stigma towards borderline personality disorder through an attachment-based training in counselor education. So at the center of this presentation is a simple question. If stigma towards BPD affects care, how do we better prepare our future counselors before these attitudes become ingrained? So today we'll briefly just look at stigma and common misconceptions around BPD, highlight why counselor education is an important place to address this issue, and then share an attachment-informed training designed to increase knowledge, improve attitudes, and strengthen counselor self-efficacy. So when people hear borderline personality disorder, there are often these kind of words that come to mind. And so I want you to think about what those words are. Manipulative, unstable, difficult, untreatable, and the big one that I have heard a lot is attention seeking. So these reactions are not just individual opinions. They reflect a broader pattern of stigma that continues to show up in research on clinician attitudes towards BPD. Yeah. BPD is consistently identified as one of the most stigmatized diagnoses in mental health care, and that's across the world. The clinicians often report frustration, uncertainty, and even reluctance when working with this population. In fact, I've had tons of clients that say, hey, I was referred out because I was diagnosed with this, because this clinician doesn't work with this population. And so that matters because stigma does not stay outside the therapy room. It can shape the therapeutic relationship. It can influence how our clients are conceptualized, and ultimately it affects the quality of care our clients will receive. And so then we look at, where is this gap? Why are clinicians not feeling prepared? And why are they clients being referred out more frequently with this population? And so much of that existing research that's out there, it looks at practicing clinicians. But when I started my dissertation, I became interested at an earlier question. And that was, where do these attitudes begin? Where does that stigma begin towards this negative attitude towards borderline personality disorder? So counselor education may be one of the most important points for intervention, because students are still starting to form their clinical identity, their conceptual frameworks, and their confidence levels. When training is limited, students may enter practice feeling underprepared, anxious, or unwilling to work with this population. And so looking at how can we prepare our counselors in training before they enter the field, so they don't have the same kind of stigma entering the field. So one of the reasons, as I was researching and working in the field, that I have found that stigma develops is how behavior gets interpreted. And so as we're looking at clients with BPD, we're looking at those the criteria, and also these words that I defined at the beginning, that manipulation, attention seeking, those are behaviors, right? And so without a strong conceptual framework of those behaviors, we're labeling them as manipulative, difficult, or attention seeking. And so attachment theory, that's why I looked at it through an attachment theory lens, it offers that different lens. We reframe it, so to speak. It starts to help us understand many of these behaviors instead as responses to attachment trauma or a fear of abandonment, as a relational insecurity, and as emotional dysregulation, rather than intentional behaviors that we're just treating the intentional behavior. So we start looking at what's underneath it instead. And so when we look at that interpretation, it's important because we start to address this, we can start addressing the stigma that is often living in the meaning of the behavior, right? So we're going underneath it a bit. We want to look at the meaning that we assign to the behavior first. So as I'm doing my dissertation, I wanted to address that gap in counseling education. And so I developed a brief attachment-based training and attachment-informed training, and it was created around 3 parts. There were 3 modules. The first module built a foundational understanding of attachment and BPD, and each of these modules was based around an hour PowerPoint setting. And so that first one, again, is that just educational piece. The second module really dove into the stigma and shifting from judgment to empathy and really looking at an attachment base, kind of bringing in that different framework. And then module 3 is where I moved into the skills, really starting to apply clinical application and teaching some of the basic attachment skills that we use, such as rapture and repair, mentalization, and just really starting to help our clients learn how to do basic regulation and start to address that fear of abandonment and create a secure base for your clients. The training wasn't just about giving information. It was designed to start shifting how our future counselors understand and respond to this population. So again, this was around my dissertation that I'm finishing at this moment, and it was refined. To start, I refined it through an initial pilot study that was created with licensed clinicians in my practice. And then after that, I did do this training with second-year graduate counseling students at a Christian university in the United States. The training was delivered through Zoom. It was through one large training through those 3 one-hour interventions. So to examine whether this training could truly influence stigma-related counselor development, I looked at 3 different areas. First up was attitudes towards BPD, knowledge related to BPD and attachments, and then counseling self-efficacy working with this population. The graduate counseling students and in the pilot study, they were asked to complete both a pre and post-training survey that covered these 3 areas. And I used paired sample t-tests to examine the change across these 3 areas. There was also some demographic data collected just to describe the sample that I was working with. And so here are the results. Overall, the training really produced significant improvements across all 3 areas. We ended up with, there were 36 participants that completed both the pre and the post surveys. We had several more people that attended the trainings but did not complete both of the things. The students showed more positive attitudes towards clients with borderline personality disorder. There was increased knowledge related to BPD and attachment, and stronger counseling self-efficacy after completing the training. The largest change occurred in counseling self-efficacy, as you can see with the numbers on the left. This really just suggests that students left the training feeling more prepared and confident in their ability to work with this population. And that was really what they talked about after the training concluded. That really matters because when clinicians have a stronger conceptual understanding and confidence, they are more likely to approach this work with less hesitation or avoidance, and they're more likely to engage effectively with clients who have BPD. So we're less likely to see them referring these clients out, which improves that client care for this population, right? So what we're seeing is even a brief attachment-based training appears capable of shifting several factors that are closely tied to stigma and counselor readiness. And ultimately, that's what we want. We want to see just these shifts that affect stigma, because we want to see a decrease in stigma all across the board with mental health. So some implications. These findings suggest that even brief targeted training within counselor education may help shift how future counselors understand BPD. When students gain knowledge, they build confidence and are given a more relational framework for conceptualizing behavior, they may be less likely to respond from stigma and more likely to engage from an understanding viewpoint. So that starts to make this a counselor education issue, not just a clinical issue. This project is an early step, but it opens the door for broader training and collaboration. For counselor education programs, supervision, and continuing education. It also creates opportunities for cross-cultural and international research on how training influences clinician attitudes towards BPD. Because stigma around BPD is not limited to one country or one training context. This is a conversation worth expanding and starting that conversation. So at the beginning, I asked what comes to mind when we hear borderline personality disorder. So these are often those default labels people have learned to attach to this diagnosis. But when we start to look through an attachment-informed lens and framework, the picture changes. Manipulation becomes struggling to express needs. Unstable, responding to attachment disruptions. Difficult, expressing intense emotions. Untreatable becomes highly treatable with appropriate supports. And finally, my favorite, attention seeking becomes connection seeking. When we shift the lens, we shift the counselor's response. And that is where stigma begins to change and we start a real conversation. If we want to reduce stigma towards BPD, counselor education has to be a part of that work and where the conversation starts. So thank you for being here and for allowing me to share this project that I'm very passionate about with you guys.